to the academic event of OGSSI Journal Club webinar May 2023, organized by the Clinical Research Committee, OGSSI, along with FOGSI. Next slide. May 9th is the birthday of Rabindranath Tagore. So first of all, paying tribute to Kobiguru Rabindranath Tagore. I would again welcome all the delegates, participants, and the presenters of this webinar. And first of all, I would like to call upon Dr. Priya Kanappan ma'am, who is the convener of this event. She is the chairperson of the Clinical Research Committee OGSSI. She is presently the consultant in OBGYN and fertility at Dr. Mehta's Hospital and Garva Raksham Ambigai Fertility Center. She has been the best outgoing student and best resident award she has got from Manipal University. She has done fellowship in ultrasound, laparoscopy and reproductive medicines, and she has presented many papers and posters in national and international conferences. Over to you, ma'am. Priya, ma'am.
Okay. So thank you. It is my immense pleasure to welcome everybody for the Journal Club. So we usually do it on the second Tuesday of every month. So for the PG's convenience, we kept it in the evening. So I'm very happy to be there, and I'm really thankful to Dr. Maitreyi Sen, who has agreed to be the master of ceremony for this program. She is currently an associate professor, Department of OBGYN in SRM Medical College. Madam has been the UG from SCB Medical College, Cuttack, and PG from Kolkata. And 13 years of clinical and teaching experience in UG and PG. She has a research interest in infertility, high-risk pregnancy, and cancer screening. Trained in level 2 fertility treatment and ultrasound, NMC coordinator at SRM MCH and Research Center. Awarded the FOGSI CS Dawn Prize for the best paper ASCOG 2023. Awarded the gold medal for the best project in Research Day 2019 and 2023. And she is a member of the IMS and awarded with funds for research product on the cervical cancer screening, presented papers in many national and international conferences, as well as in international journals. She is awarded the 5 years merit scholarship in her MBBS from Odisha. So over to you, Madam, Dr. Maitreyi Sen.
Yeah. Thank you, ma'am, for the introduction, but it was quite lengthy for me. I am a very small part.
No, but it's very nice. You have so many medals. They are like very good credentials.
Yeah.
Over to you.
So let us start the event with Tamil Thai Waltz. I request you all to please rise up for Tamil Thai Waltz. I would like to request Jairani ma'am and Kundavi ma'am to please light the lamp. Thank you. I'm privileged to welcome Jairani ma'am, who is the present president of OGSSI. She is the senior consultant of reproductive medicine and director of Akash Fertility Center. And she is the treasurer of TAPISAR, Associate Secretary, Advisory Council member of World Association for Sexual Health. She has been a member of ISAR, FOGSI, ASRM, and ESHRE, and she has to her credits lot of medals and awards. She has been awarded the gold medal in MBBS and also post-graduation. She has been awarded the Best Woman of the Year 2010, Women's Service Award by Exnora 2010, Mega TV Women Achiever Award 2011, and I welcome you, ma'am, again to be a part of this webinar, and I would request you to please give the welcome address.
Thank you, Maitri. Thank you so much for the lovely introduction. Thank you, Priya, for making this journal club very consistently in a beautiful way. And a very special thanks to my clinical research committee, all the co-chairs and the chairs and all the members. And a very special thanks to my secretary too for organizing everything. And a very important thing that we are running through, a very important aspect is the very good support from Foxy. Dr. Surekha is here. She's doing a very nice work to coordinate with Priya to bring about the good knowledge sharing, the research methodology, and many other things related to the research. So we have wonderful Dr. Nikita to share on a lot of interesting things about the research methodology, and we have the third module this time. And I'm very happy and thankful to about Dr. Nikita for being in this journal club to give all the insights about the research methodology. And a very special thanks to Surekha and all the delegates, postgraduates here who are here for this webinar. I wish this webinar will be continuing with still more, lots and lots of important knowledge sharing and the very important aspects in the research methodology. Thank you, Priya, and thank you, Maitri. Over to you.
Thank you, ma'am.
Yeah.
I'm very happy to invite Dr. Kundavi ma'am. She is presently the Honorary Secretary of OGSSI, HOD and Senior Consultant at IRM MMM Hospital. She has been an active member of OGSSI, IMA, ISAR, TAPISAR, and Academic Secretary of TAPISAR. She has been a specialist in reproductive medicine and laparoscopy surgery for more than 20 years. She has also many fellowship program at IRM MMM, and she has been invited as a faculty in many conferences and has to her credit a lot of publications in reputed journals. She has been an examiner of FNB and MGR University Fellowship Program. She has been also the chairperson for Anti-Sexual Harassment Committee MMM. Ma'am, I would request you to please recite the OGSSI prayer.
Thank you. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when things are not perfect, and to remember that we are but the messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. I would again request Jairani ma'am to please introduce our chairperson of OGSSI Clinical Research Committee, Dr. Surekha Tayade.
Thank you, Maitri. It's a great pleasure and honor for me to introduce Dr. Surekha, who is the chairperson of the OGSSI Research Methodology Committee. And Surekha has many laurels, and she is the West Zone Coordinator for the Practical Obstetric Committee, and she's the member of the Education Committee of the Indian Menopause Society, and she's the chairperson of the Global Women's Health and Task Force Network, and she has she's a faculty at the Veera project of OGSSI, and she has the founding member and the vice chair of the Women's Health Together for the Future of in South Africa, national mentor for the Quality Improvement and Lakshya program. Lots and lots to her credentials, and she has been a very active person in publicating more than 108 national and international publications, and she has done a lot of projects and authored many books and a lot of publications. And she is a real right person to work for the OGSSI Clinical Research Committee. Very apt person, I would like to say, such a nice person and a good friend of mine. Over to you, Surekha, to say a few words.
Ma'am, madam is held up in an emergency. She will not be joining it.
Okay. So okay. Over to Priya to take over.
Jairani madam, can you introduce our expert for today's session, Dr.
Sure. I'll do that. Gives me great honor to introduce Dr. Niveta, who is the Associate Professor of the Department of OBGYN from JIBMER, Pondicherry. Madam has a lot of affiliations. She's an easy member of the OGSSI Clinical Research Committee between 19 to 25 till now. She's continuing very actively in the committee. and she is an EC member of the FOXI Medical Disorders in Pregnancy Committee between 19 and 22. She has publications over 40 papers in high impact PubMed index journals and authored several books and chapters, and has involved in very many funding projects as a principal investigator. And she's the peer review of the BJOG, BMC, Pregnancy and Childbirth, Journal of OBGYN, Research Journal of Maternal and Fetal Neonatal Medicine, and very many things on her credit. Over to Dr. Niveda, who is the present Associate Professor of Department of OBGYN, JIPMER, Pondicherry, for her nice talk on this clinical research in our journal club. Over to you, Niveda.
Thank you. Thank you so much, ma'am, for this kind introduction. It's indeed an honor to be here with you all, to be connected with OGSSI team. Thank you for the opportunity to invite me, ma'am. So I hope we make the program more interactive.
Yeah.
Thank you, ma'am. Jairani madam, can you introduce Sunita madam also?
Yeah. It gives me great pleasure and honor to introduce our lovely Sunita Samal, who is very active person right now in all our committee meetings and all our OGSSI meetings. Madam is the former HOD of SRM Medical College, Katangalattur. She is a former professor of MGMC and RA in Puducherry. She's a UG and PG teacher for more than 17 years, and her special interest is in laparoscopy, hysteroscopy, and vaginal surgeries, and high-risk obstetrics and basic infertility medical education. And she has more than 50 publications in various national and international journals. Madam has awarded the Best Poster Award at ASUT 2015-17, first prize in FOXI Zonal Quiz in 2002, and she has got the Dr. Anjalaksha Chandrasekhar Award for the best research paper from our Oxycon last 2020, and she has been awarded as the International Scientist Award on Science and Medicine in 2021. She has conducted a lot of CME, organized many CME and national educational programs, and she has presented various national and international conferences. And she is a present member of FOXI, OGSSI, IAGA, and MSc. Over to you, Dr. Sunita. Welcome you. On behalf of OGSSI 2023, I welcome you.
Thank you, ma'am.
Thank you for kind words. Thank you, ma'am. Thank you for this opportunity also. Thank you.
Thank you, ma'am.
Thank you, Jairani
without-
madam. Now Dr. Maitri will take over.
Yeah,
Thank you.
yeah. Thank you, Jairani ma'am. Welcome you all again. Let us not waste time and start the session 1, which will be led by Dr. Nikita Prabhakar. She is a regional medical officer, completed her MBBS from St. John's National Institute of Health Sciences, Bangalore, MBA from Annamalai University. Health Research Methodology course has been done by her from St. John's Research Institute, Bangalore. Currently, she is working as a regional medical officer, South at Abbott India Limited. Over to you, Nikita ma'am, to start with your lecture.
Thank you, Dr. Maitri, for the introduction. Without any further ado, I'm going to share my screen and we can get started.
Yeah.
I hope my screen is visible.
Yes, ma'am. Yes, ma'am.
Perfect. So a very good evening to all the students who have logged in and to all the panelists and especially all the dignitaries of the dais. It's my pleasure to be here this evening to take the third module of clinical research methodology in this workshop. I hope the past 2 modules have resonated with you and you were able to remember and retain some of the knowledge that has been imparted. So what I will be covering in today's module is essentially sampling and handling biases and confounding in clinical research. So just jumping right to it, what would be a sample, an appropriate sample whenever we conduct a study? So a sampling, the frame which we are to consider is what is the geographical region we are looking at and what are the set inclusion and exclusion criteria that we would consider when we're going to do sampling of a population. Firstly, a sample has to be representative of this population that we are studying, because there has to be generalizability or external validity of the study only when the sample is representative. In the event that the sample is unrepresentative, there will be no external validity to the study and your study will not be generalizable. So essentially, we are to draw a sample which will, the study when we conducted on the sample, we should be able to infer results about the population based on the sample that we draw. Now, how do we get generalizable data? First, we should have rational inclusion and exclusion criteria. Random sampling must be performed. Stratification or stratified random sampling is preferred. Even in randomized control trials, multi-centric randomized control trials have to be conducted, and hypothesis testing can be done, and in order to claim legitimacy of a study once you have generalizable data. So what are the various sampling methods? In case of probability sampling, there are various types, starting with simple randomized sampling, stratified random sampling, cluster sampling, systematic sampling, and multi-stage sampling. In case of non-probability sampling, we have volunteer sampling and convenience samples. So under convenience samples, unfortunately, it's based on, fortunately, it's based on human choice rather than random selection. So there's excessive amount of bias when it comes to convenience sampling, and statistical theories cannot explain how they might behave or might not, because again, once again, like I said, they're subjective to excessive amount of bias. So how do we go about simple sampling? Simple random sampling is, in a given population, you assign numbers to your given population, and out of them, you randomly pick out any number from this population that forms your sample. It's a lottery method or a table of random numbers. And this can, of course, only be done when your population is small. So let's say you're collecting information from a particular district, or even better, you're only collecting it from a certain area or a certain strata of population. So you're limiting your population further. So it's a lot easier to conduct a simple random sample from such a small population. Now, systematic random sample is when you have the complete list of population from which your sample has to be drawn. You number them from 1 to 12, 1 to 20, 1 to 500, whatever it may be. And then you decide that every third sample or every fifth sample, you fix the number and you say that every third sample, for instance, I will be collecting. So that way there's some sort of systematic order, but at the same time, it remains random. Stratified sampling, in this case, we ensure that there is stratification that are done, right? So if you look at my population here, sample population here, you'll find that I have color coded it so that I have a quarter of my population falling under blue, a quarter of my population falls under green, and half of it falls under red category. So an ideal sample will be representative of the population, right? So my sample should also have a quarter blue, a quarter green, and half of red. Now this can be achieved only once you stratify your samples. In cases of multi-stage cluster sampling, let's suppose that we have 12 individuals, that is my population, right? You pair them up as, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and then pick out pick out only specific clusters. So let's say, I have a nationwide survey that I'm conducting, right? Each district, for example, or each state can be a cluster. You choose which cluster you're picking out. You pick out random clusters out of this entire nationwide population, and that becomes your multi-stage cluster sample, right? Since we want only a random sample of, say, 4 out of this 12, I've only selected 2 random clusters. Now, again, even the selection of the random, you number each cluster as 1, 2, 3, 4, 5, 6, and using technology, you randomize even the clusters which you're going to be selecting out of your cluster sample. Then stratified sampling, like I mentioned, it is more representative of the population and makes your sample more homogeneous in nature and easier to compare. Now, when we compare, what is the difference between a cluster sampling and stratified sampling? Let's say, for example, I am considering the population of all diabetic patients in West Bengal, right? If I'm going to do cluster sampling, I would make 20 clusters, for instance, according to the 20 districts that are there in West Bengal. So each district forms a cluster. Whereas in stratified sampling, I would make 20 different strata, right? And according to 20 districts itself, each district I have the same stratification applied. Now, if I have to obtain a simple random sample, I would choose 5 clusters or 5 districts out of the 20. Whereas here, I would choose 5,000 people from each of the 20 districts in case of stratified sampling. So the sample in case of a cluster sampling will essentially be all the patients in each of these selected 5 districts. Whereas in a stratified sampling, it will be 5,000 from each district into 20 districts, or a 1 lakh population, diabetic patient population, right? So you see the sort of uniformity that's there in case of a stratified sampling. Now, what is the significance of sample size calculation? Number one is it improves precision. It gives adequate power to a study, which we studied last time, how to calculate the power of a study, 1 minus beta error, right? Or type 2 error. There is also economic viability, in the sense there is no wastage of resources that are allocated to the study. And there's also ethical consideration, wherein you do not oversize a study wherein an unnecessary treatment or protocol is not given or to a large amount of population. Likewise, a potentially harmful treatment is not given to a larger set of population. So oversizing or undersizing are also ethical considerations to look at when it comes to sample size. What are some of the factors that affect the sample size? The type of study that we're undertaking, the type of primary outcome we're looking at, the power of the study, what are the expected variability between the subjects, what are the critical important effect size? Again, we studied last time what effect size is. And finally, what is the expected attrition rate you are looking at in terms of your patient flow, like in a cohort study, for example. And of course, availability of subjects. That's the most important. So essentially, that's just a brief about sampling. And with that, I will go over to handling of confounding and bias, because unfortunately or fortunately, this is where, you know, a lot of what do I say, issues arise when it comes to research methodologies. How do we handle these confounding and how do we handle biases? So introduction of bias can happen at any stage when you're conducting a primary study, right? Right at the outset, when we're recruiting participants, you can have selection bias. When you are allocating them into an intervention group or a control group, again, allocation bias can occur. Confounding factors may be, for some reason, dissimilar in the two groups. Then it comes to withdrawals, there are dropouts, improper blinding or outcomes. You know, at any stage, bias is a possibility, right? So what are some of the tools that we can ensure to take on to control confounding? Now, right in the study design phase, some of the tools include randomization of your sample, restriction, matching, and stratification. Now, once we're in the analysis phase, also you can control confounding by means of stratification and multivariate analysis. I'm just going to go into each of these now. So what is randomization? Randomization ensures that all the factors are balanced out between the treatment group as well as the control group, so that both the groups are almost alike. So the patient, neither the patient nor the physician will know in advance which therapy the patient will be assigned to. So every patient has an equal opportunity of or chance of receiving either the treatment or the study. So randomization reduces selection or allocation bias. Now coming to types of randomization. First comes simple randomization. So here it's a typical, it's not exactly a flip of a coin, but you could say it's a, you know, heads or tail, like you flip a coin by means of either some sort of technology, computer randomized number generator technology, wherein you decide, you know, whether the patient gets treatment A or treatment B. So the issue is now, how equal will the distribution of your patients be in case of a random flip of a coin, simple randomization, right? It's unlikely. So in a patient where you're looking at, what do I say? Equal number of patients, you need equal number of patients in the control and in a treatment arm. In simple randomization, that it may not afford you the opportunity to have balanced treatment and control group. And more importantly, a baseline factor, okay, the baseline factor may be unequally distributed. Like, for example, I've taken the example here of coronary artery disease. Now, I am assessing a particular drug in patients with coronary artery disease, right? And I have 200 patients. In that, 100 of them are more than 75 years and 100 of them are less than 75 years. Now, we all know the likelihood of mortality or even morbidity when it comes to coronary artery disease is far more likely in those who are more than 75 years of age, right? So if I have done a simple randomization in my sample and I've assigned 100 here, 100 here, you know, equal. However, my test has 60 patients who are more than 75 and only 40 less than 75. And my placebo has more patients who are less than 75 and lesser patients at 40 patients more than 75 years. Naturally, the mortality is going to be excessively high in the test group compared to the placebo group. Now that can give you skewed results. So this is one of the major problems wherein the baseline factors are not properly distributed in case of a simple randomization. So what is the solution? That's why we have blocking or block randomization and or stratified randomization. So here, for example, this is block randomization, right? So where treatment A is a test group and B treatment will be the placebo group. So essentially what happens is we put various blocks depending on your sample size, either it will be blocks of 4 or blocks of 6. And we first and foremost stratify the patients, right? We put them as patients, for example, in my osteoporosis study, I have stratified my sample based on the age, the baseline factor of more than 60 years and less than 60 years. And I have put my patients in these respective blocks, wherein out of my 47 patients, 24 are in block A and 23 are in block B. And I'm exactly aware how many patients are receiving treatment group A and how many patients are receiving treatment group B in both these strata, right? Why? Because I've done block randomization. Now, what is this block randomization? Let's say I have created blocks of 4 here, right? Each block will have a different algorithm. So as and when my patients are filling into the block, they receive their treatment based on the preset algorithm in place. So for example, my algorithm here, right, is the last line which came in, BAAB. So as patients are recruited, first patient B, second patient A, third patient A, fourth patient B. Now I have not preset this block. It is randomly assigned as and when the patients are allocated to the block, right? So this way, first of all, we ensure that each block receives equal allocation of treatment and placebo, and also you have an account of how many patients are in the placebo group and how many patients are in the test group within each strata also. So blocking is only this, putting it as sets of 4, and stratified is, apart from putting it as sets of 4 or blocks of 4 or blocks of 6, you are also stratifying your sample based on a baseline factor. For example, I've taken age as a baseline factor. They can also be gender. You can also have exposure, for example, smoking status, alcohol consumption status, anything can be a reason to stratify your sample if you feel like that is a confounding factor that's going to affect your outcomes. Blinding, this is now another tool for handling confounding right at the study design phase. So what you do is you mask the identity of the assigned intervention. So the main goal here is to avoid potential bias, which can be caused by conscious or subconscious factors. So which brings us to the types of blinding. There's single blinding, double blinding, and triple blinding. Single blinding is only the patient is blinded. The patient doesn't know whether they're receiving the placebo or the drug. Double blinded is both the patient and the assessing investigator, right? Both are blinded. And triple blinding is the person who's doing the analysis of the data is also blinded. Now, why should patients be blinded? Because if patients know that they're receiving an experimental drug, they may report more or in some cases even less side effects. If patients come to know that they're not receiving the drug, they may be more likely to drop out of the study. Also, patients may have some preconceived notions about the benefits of the therapy, so they might have these placebo effects. And also, if patients are wanting to please the physicians just to get well, they might appear to be getting well, but actually nothing might be working, right? So it's always essential, whatever you do, patients must be blinded in a study. How do you do blinding? You can use a pill of the same color, the same shape, size, odor as a treatment, or you can also do something called the double dummy method, wherein in the first group or the treatment group, the drug is blue and the placebo is red, whereas in the treatment group 2 or the control group, the drug is red and the placebo is blue. So that way, nobody knows what they're receiving, right? And there's also something called a sham operation or sham device. Now, this is more for surgical studies. For example, I've taken the example of a randomized control trial of arthroscopic surgery, which was done for osteoarthritis of the knee, where they were undergoing arthroscopic surgery, and there was a procedure to place a certain, device arthroscopically. Now, those who were in the placebo group were not receiving this, right? They were rather only getting a debridement done. They underwent the procedure, but only a debridement was done without the insertion of the arthroscope. So this is a sham operation. Likewise, sham device, I've taken the example of a study, which is laser therapy for diabetic peripheral neuropathic pain, wherein a particular laser therapy was done. Those who were in the treatment or experimental group, they received this laser treatment twice a week. Those who were in the control group, they had a sham treatment where it was only red light, a device which emitted red light that was being applied and not the typical laser treatment. So sham treatment or sham operations are also done with ethical considerations to being taken into consideration, of course. Can blinding always be done? No. In some studies, it may be impossible to blind the patient, or it may even be unethical to bind the patient. Why? Because the treatment itself may have certain characteristic side effects. So naturally, those who are in the placebo group will know when they're not having the side effects that they are in the placebo group. Or it may be even difficult to blind the physician in the surgery or device, because naturally they are to insert the device, right? So it might be difficult to blind the physician. So blinding cannot always be done. Now, next tool would be restriction or specification. So this is by restricting the recruitment to only those who are falling within a specific level of confounding variable. Like, for example, if I'm going to do a study on exercise or heart disease, I would restrict the study to men aged 40 to 65 years, right? Now, the advantages are that it's a straightforward study, it's convenient, and it's inexpensive. Disadvantages are it's limiting my sample size to of eligible subjects. It's limiting my ability to generalize the study in the whole population. It's only limiting it to this particular age group. Number three, you cannot evaluate the effect at different confounding levels. So there are advantages and disadvantages. However, this is also one particular means of handling confounding. Matching. Now, matching, this is more appropriate for case control studies, wherein you match the cases and controls on a very strong confounder. For example, in a coronary artery disease study, I would think smoking is a very important confounding factor. So I would want that to be matched in both the cases and controls. Now, usually this requires a special analysis techniques like matched pair analysis or conditional logistic regression. Disadvantages are finding a control would be a task, right? Difficult, costly, and it might also limit the sample size. Matched confounder can't be evaluated with the outcome, whatever, for example, smoking in my case. And you cannot doesn't control all the confounders, only the ones which you have matched will be controlled, right? Like in my example of I'm evaluating the outcome of coronary artery disease, I've only matched my controls and cases based on smoking. I have not matched them based on caffeine consumption or sleep or occupation. So naturally, those confounding factors can't be controlled. Not all the confounding factors can be controlled. Then coming to stratification, I already mentioned this in brief before, wherein you produce groups within the which the confounder doesn't vary. For example, I'm going to stratify an osteoporosis study based on those who are more than 60 years, less than 60 years, because within that less than 60 years or within that greater than 60 years, the variability is very low, right, within each of those strata. And then I evaluate the exposure disease association, which within each stratum. So for a person who's 55 years, this is the sort of association between disease and outcome, disease and exposure. Whereas those who are about, say, 70 years, the exposure disease association is like, so definitely there will be variations, but your evaluation will be on point, right? So this is a example I've taken in case of a CHD or smoking. I have taken CHD wherein I've compared outcome is CHD and exposure smoking. And my 2x2 table, if it's a cohort study, I would calculate a relative risk here, which we already studied measures of association, right? A plus B, incidence in exposed divided by incidence among the unexposed. And in a case control study, I would do an odds ratio, which is AD by BC. Once I calculate my odds ratio or my relative risk, depending on the type of study, first I have to create a crude odds ratio table. Crude is based on this numbers, 100, 400, 25, 475. That is your, a crude odds ratio for you to compare with each stratum. Then as you stratify it as, stratum 1 and stratum 2 for whatever, let's say I've made a stratum based on age, more than 60 years, less than 60 years. Now you have to calculate the odds ratio for each of the stratum. Odds ratio for less than 60 years, odds ratio for more than 60 years. Now, if stratum specific odds ratio are similar, then calculate odds ratio of the strata. And finally, what is the point of calculating the different odds ratio? If the crude odds ratio, which is the top, the entire general odds ratio, is not equivalent to the odds ratio of these stratum, then confounding is likely, or meaning to say there's more than 10% difference. But if your crude odds ratio is equivalent to the odds ratio of even the stratum, then confounding is unlikely, right? Because if you're finding that much of a difference in your odds ratio, then you're definitely sure that there is confounding here. This is definitely an age factor. Like, for example, if I'm talking about a drug and I'm talking about confounding based on age, right? If I'm getting the same amounts of odds ratio, between the crude and the particular stratum, that means that age was never even a factor in this whole process, right? So this is how you do a stratified analysis. Now, stratified analysis you can do this way when there is only one confounder, right? How easy is this as odds ratio 1, odds ratio 2, and compare with crude? Now, let's say I have so many strata, based on age group and, based on obesity, for example. Based on age group itself, I have created multiple, like 1, 2, 3, 4, 5, 6 stratums here, right? In this case, not only have I created based on age group, but I've also created based on family history. So first, you have to divide patients based on age group. Then you divide them based on whether they have family history of heart disease or not. And then I further divided them as males and females. You see where I'm going with this, right? Where it was just one age factor as a stratum, it's easy. But when you have so many confounding factors that you are looking at, it's not easy to sit and calculate the odds ratio of each of those mini stratum and compare it with the original crude odds ratio, right? So let's like for example, my really complicated strata is here. I've stratified by gender, I've stratified by age, and I've stratified by smoking status as 3 levels: never smoked, former smoker, and current smoker. Now I have 30 different substrata. So how do I analyze this data? By means of multivariate analysis, right? So stratified analysis works best only when there's 1 or 2 confounders. But if there are multiple confounders, then the potential number of confounders is large, you can only do a multivariate analysis to offer a reasonable solution. Now, what is the benefits of this? It can handle a large number of confounders or covariates simultaneously based on statistical regression models. So either you can do a logistic regression or multiple linear regression, and you can always get it done with the statistical software packages, which we know is available, right, in our colleges. So that this I actually went into a little bit so that it's easier for the next class, but not to worry, we'll take this in detail next time, right? But this is essentially how it works when it comes to stratification. Now, residual confounding, this is confounding that can persist even after all these adjustments. Now, this was also can be, these are additional confounding factors either that was not considered, or there was no attempt made to even adjust for them, or the data on these factors was not collected. So because of that, you were not able to, handle the confounding appropriately. Or for all this, confounding was measured with error, or categories of the confounding factors may have been improperly defined. So these are the various reasons for you to have some amount of residual confounding. So you have understood how to handle confounding and bias when it comes to the study design, and how to handle it based on the number of confounding factors that we have. So just to sort of briefly understand how to find out association between 2 variables before we go into the next session would be, if it is a numerical data and both are parametric, then you look at Pearson's correlation coefficient. Now, if it is, or you can look at linear regression. Now, if they are not parametric data, you have to do Spearman's correlation coefficient. If it is categorical data in place and you can do a 2x2 table, odds ratio, relative risk is the way to go. Otherwise, you have to do a chi-square test or logistic regression table, right? With that, I'm going to stop because this is again a lot of information. So thank you for your time, and I am happy to keep the rest for the next module. Thank you, everyone.
Yeah, thank you, Dr. Dikita. Actually, you know, in our scientific committee, most of the studies are objected due to this bias and confounding factors. But I was really happy to hear get the knowledge from you. But still, I will tell that we need help of you people to study our studies, whether we are away from these biases and confounding factors. Thank you so much. Thank you so much.
Thank you, ma'am.
Shaiti, we will go to the next session. So we will go to the session 2. As you know, all the IPL match is going on. I will just simulate it to like a IPL match, and the player today is Dr. Jivita. She's a DNB resident from Apollo Hospital, and she will be presenting the journal club on the role of vaginal progesterone on preterm birth prevention in women with threatened labor and short cervix diagnosed after 24 weeks of pregnancy. So Dr. Jivita will be our player. Dr. Sunita Samal ma'am, who will be moderating, will be the captain of the match, and Dr. Nivedita will be the umpire. So let's go ahead with the match. Over to you.
Nice comparison. Yeah, Dr. Jivita.
Dr.
Sahitya,
Jivita?
like Dr. Jivita is there?
Jivita.
No, ma'am.
Because actually she was there with the delegate link, madam, and she was not able to share the screen. So I
Okay,
gave her
okay.
the link. I think I'll just
Yeah, I'll just call her because just now I spoke to her. She didn't.
yeah, because she said she didn't have the share screen option because she
Okay,
didn't join through the speaker link.
Okay,
So
okay.
one second, ma'am, I'll just confirm. I gave her the link.
No, I'm calling her.
Yes, ma'am.
And Jivita, have you joined?
Ma'am, I have given permission to Jeevita ma'am to join in panelist.
Perfect.
Yeah.
So
Ma'am should accept it. Yeah. Just now ma'am has accepted.
she's accepted.
So.
Perfect. Thank you.
Yes,
Thank you,
told
Sahitya.
she joining. So before she joining, I just wanted to tell like why we choose this preterm birth, because all of us know preterm birth like almost like 10 to 15% incidence in India, and it is the major cause of like neonatal and the infant mortality and morbidity. So, and we have many studies like in preventing preterm birth starting from the first trimester, second trimester, like in different forms of progesterone, either it is oral or it is a vaginal or injectable progesterone. But I didn't see any studies which is used after 24 weeks, because we need to prevent preterm means you are doing it just before the like 24 weeks. So now this study, though it is a retrospective cohort study, but I feel maybe it will be helpful, and we can also discuss regarding this journal article. So we have chosen this study for that purpose. Jivita?
Yes, ma'am.
Yeah, can you share the screen?
Hi, Dr. Nivedita. Have you joined recently in JIPMER?
Hello, ma'am. Good evening. I have been here since 2018.
Okay, I left Pondicherry in 2017. Okay, because I was
I
there
know
in
you must
Mahatma
have-
Gandhi for almost 11 years. So because I
Uh,
know each and every faculty of JIPMER, that is what I just asked. Okay, nice to meet
I have
you in this
attended
forum.
PMC on the course. I have a
Okay,
I-
okay, thank you. Yeah, Jipita, start. You can start.
Yes, ma'am. Am I audible, ma'am?
Yeah,
Yes.
you are audible.
Yes, ma'am.
Good evening, all, ma'am. I'm Dr. Jeevita, Secondary DNB Registrar from Apollo Women's Cradle. I'm presenting this journal club today under the guidance of Dr. Sunita, ma'am. Thank you, Oxy, for this opportunity. The article today I'm discussing is the role of vaginal progesterone in preterm birth prevention in women with threatened labor and shortened cervix diagnosed after 24 weeks of pregnancy. This study was conducted by Dr. Doran and Habri and Dror Reif Nasher in Hadassah Hebrew University, Jerusalem, between the study period of March 2010 and January 2017. This article is published in International Journal of Gynecology and Obstetrics. This topic basically deals in preventing preterm birth, how the role of vaginal progesterones in preventing preterm birth when administered after 24 weeks of gestation. preterm birth is a leading cause of perinatal mortality and morbidity worldwide. It is one of the leading cause of under 5 deaths. Predicting and preventing the preterm birth is a major healthcare priority. The indicators of threatened preterm labors are like irregular contractions, low backache, vaginal discharge, and bleeding, with or without the shortened cervix, which will lead to threatened preterm delivery. So sonographic short cervix is the most powerful method of predicting the preterm birth. So the various modalities that are used when a patient presents with a preterm labor are vaginal progesteron, cervical encerclage, and cervical pessaries, of which the vaginal progesterone has is very effective in reducing the rate of preterm birth when a woman presents with a short cervix. Cervical encerclage is also equally effective in patients who are presenting with short cervix. Cervical pessary has been recently is used by many faculties, and it is a subject of ongoing studies. Most of the randomized controlled trials have focused on patients diagnosed with a short cervix before 24 weeks of pregnancy. This study, particularly, it deals with administering vaginal progesterone to women with threatened labor and a short cervix who are diagnosed after 24 weeks of pregnancy, and they have evaluated the outcome in terms of reduced preterm births and lower NICU admissions. So the main objective, as I told before, is to determine whether the vaginal progesterone given to women who presented with threatened labor and a short cervix after 24 weeks of gestation has resulted in a reduced preterm birth. So the materials and methodologies. It is a retrospective cohort study. It was done in the study place is Hadassah Hebrew University of Medical Center, Jerusalem, conducted between March 2010 to January 2017, and it was published in 2022. The sample size is 3,871 antenatal women with singleton pregnancies between 24 to 36 weeks of gestation who came to the hospital were all screened. The inclusion criteria is all the singleton pregnancies between 24 to 36 plus 6 weeks of gestation. And the exclusion criteria included all the multiple gestation and the women with major fetal and uterine anomalies, history of conization, history of previous preterm births, a short cervix diagnosed earlier in the index pregnancy, PPROMs, preeclampsia, placental insufficiency, and patient whose incomplete data, patients with incomplete outcome data, and patients who also delivered within 1 day from the day of diagnosis. Methodology. The decision to prescribe the vaginal progesterone has been made by the attending physician. The administration usually began at the diagnosis and the treatment continued until the delivery or until 36 plus 6 weeks of gestation. The vaginal progesterone that is used is a micronized progesterone, 200 milligram capsules that is given at the night before bedtime. The drug dose and the method of administration and the progesterone treatment groups were similar. Any difference in the method or dosage or administration, those patients were all excluded from the study. So this is the thing. Out of 3,871 women who came to the hospital during the study period between 24 to 33 plus 6 weeks of gestation were screened, and out of which 3,228 women had a cervical length more than 25 millimeter. Only 643 women had cervix length less than 25 millimeter, out of which 216 women were excluded based on the exclusion criteria, and only 374 women came under the study population, out of which 121 people received micronized progesterone and 253 people did not receive any progesterone. So the statistical analysis, all the differences in the continuous variables were calculated using t-test, independent samples using t-test, and the differences in categorical variables were calculated using a Fisher exact test. Significant p-value less than 0.05 was considered statistically significant. The diagnosis to delivery interval was assessed by the Kaplan-Meier method, and the Cox proportional hazard model was used with a formal test of the proportional hazard assumption to adjust the risk factors and the calculation of hazard ratios. Outcomes. The primary outcome was just to measure the spontaneous deliveries before 37 completed weeks of pregnancy, and the secondary outcome were divided into maternal and neonatal. The maternal secondary outcomes were spontaneous delivery before 34, 32, and 28 weeks of the pregnancy. diagnosis to delivery interval, gestational age of delivery, tocolytic therapy, antepartum administration of corticosteroids, the mode of delivery, and the length of hospitalization. The neonatal outcomes were assessed as neonatal birth weight, Apgar score at 5/5 minute, and NSU admissions and the severe prematurity and the morbidities. So these are the baseline characteristics that were included in both the study populations. It included both all the following things: the maternal age, nulliparity, gravidity, previous cesarean women who had previous cesarean deliveries and previous preterm births, and the gestational age at which they were diagnosed with the threatened preterm labor, either before 30 weeks or after 30 weeks, and the cervical length during the time of diagnosis. The cervical length was further categorized into three as the length between 0 to 9 millimeter, 10 to 19 millimeter, and 20 to 25 millimeter. Less than 15 millimeter, they took it as a severe short cervix. These were the outcomes. Maternal outcomes, as we told earlier, they were calculated as a gestational age at birth, diagnosis to delivery interval, tocolytic therapy, which was given for to prolong the preterm labor, and antenatal.
Jipita, here when you present that, you have to tell the important findings here.
Okay, ma'am.
When you are telling the outcomes of the baseline characteristics, what is the baseline means in study group and the control group? Which one is the important thing that you have to mention? Okay.
Okay, ma'am. The baseline characteristic of the study population, there is no great, almost both the progesterone group and the group which doesn't receive the progesterone almost has the same baseline characteristic. The maternal age averagely see will like almost like 29 years in both the groups, and the nulliparity where nulliparous women were 55 in the progesterone group, whereas it is 114 of 253, which is again the 45, which is almost the same. So the baseline characteristic compared in both the groups are almost having same characteristics. The cervical length as well as seen here has almost the same characteristic, like it is 2.5 and it is 1.6. Basically, they mean to say that the treatment group, both the groups who receive progesterone as well as non-progesterone has the same baseline characteristic. So the study comparison has been easy. And the maternal outcomes, the secondary maternal outcomes were analyzed based on the gestation age at birth, the diagnosis to delivery interval, tocolytic therapy they have given to prolong the preterm birth, and the antepartum steroids administered to prevent postnatal neonatal complications, and the mode of deliveries. Of this, the significant p-value was seen in diagnosis to delivery interval. The people who took progesterone had a significant increased antenatal period, and they approximately delivered at 8 weeks after the diagnosis, whereas the people who doesn't receive the progesterone delivered around averagely 6.6 weeks. And the neonatal outcome were assessed as per the Apgar score, birth weight, NSU admissions, and the rate of hospitalization, days of hospitalization. There was significant decrease in the NSU admissions in the progesterone receiving women. There were just 10 admissions out of 121, whereas the people who had not received treatment, there were 41 neonatal admissions out of 251. So statistically, which is...
Jivita, sorry to interrupt you. In your this slide and previous slide, it's very difficult to make out because, you know, you should always write total number and percentage. In progesterone group and no treatment group, what is the N? And then these tables should have the percentage, because see, progesterone group, we know there were 121 patients and no treatment, 365. Yes. So yeah, yes, so it's not clear from this picture, but a person who looks at your outcome results should be able to understand everything about the study, or a person who reads your discussion should be able to understand everything about your study. That's how you have to put it. So progesterone, you should write N, and in these columns, tocolytic therapy, you can write both N and percentage. So it's, to my eyes, to the viewer's eyes, it's easily understandable, and directly we look at the significant values. Okay.
Okay, ma'am. Shall I proceed, ma'am?
Yes. Yeah. I think you have forgotten to put that N number here. Because
Yes,
when
ma'am.
presenting always that number, if it is there, see, everybody doesn't remember, no, how many number of patients, what is the study
So
group and control
percentage,
group.
Yes, ma'am.
yes, you should mention, because you see antipartum corticosteroid 208. I think that in no treatment group more
Yes,
were
yes.
given, but it's very less. Now percentage wise, it's very less.
Ah.
Out of 361 only 208, isn't it?
Yes, ma'am.
Yes. So this you should take care.
Yes, ma'am. Next time I'll
Oh,
facing the presentation, I'll make sure that put the 10 and percentage as well, ma'am.
go ahead. Yes.
So this table shows the spontaneous preterm birth rate in both the study groups. This blue is the non-treatment group and the red shows the progesterone treatment group. It significantly shows that people who have received progesterone had a decrease in the preterm birth rate before 37 weeks. Before 28 weeks, there is no much difference uh, between the treatment and the non-treatment group, whereas the gestation progresses, there is a significant decrease in the preterm birth rate in people who have received progesterone. So this is a Kaplan-Meier curve. This is projected to show the diagnosis delivery interval. The red line is the curve who have received the women who have received the progesterone treatment, and the blue depicts the group which has not received the progesterone. It is quoted like based on the cervical length measurement to the delivery. Significantly, the people who have received progesterone has increased the diagnosis to delivery time. And this is a Cox proportional hazard regression chart, which shows that progesterone treatment, people who have taken progesterone treatment had a significant p-value. Other parameters that was adjusted at a hazardous adjustment ratio were cervical length, previous preterm births, and the maternal age. So the main discussion is from this study, they have tried to prove that administration of vaginal progesterone for preterm labor and the cervical length of less than 25 millimeter who are presenting after 24 weeks of pregnancy were associated to have a lower rate of preterm delivery. There is a significantly increased diagnosis to delivery interval. And in the neonatal outcome, there is a decrease in NICU admissions. All the guidelines for the administration of progesterone in case of preterm labor was designed just to give before are formulated for just before 24 weeks of gestation. There is no guidelines for the usage of progesterone for threatened preterm labor after 24 weeks of gestation. This is another study, optimum study, does progesterone prophylaxis to prevent preterm labor, improve outcome. This trial was published in 2016. It is one of the largest trials to evaluate the effect of progesterone after 24 weeks in threatened preterm. This also included the childhood outcome at 2 years also, which is not included in this study. But this large trial showed the conclusion that the vaginal progesterone was not associated with the reduced risk of preterm birth or composite neonatal adverse outcomes and had no long-term harm or benefit on outcomes in children at 2 years of age. So basically the strengths of this study, it is a relatively large patient cohort study. It had strict inclusion-exclusion criteria. The study design was to include only those who had potentially benefit from the progesterone therapy and to exclude those who were receiving other treatments to prevent preterm birth. Only few randomized control trials were done on the similar topics. We could not find much of the randomized control trials where progesterone has been administered after 24 weeks in preterm labor. And the limitations is, since it is a retrospective study, it is more prone for selection bias, and it is purely the obstetrician's decision to whether initiate the progesterone or not when the patient is presenting after 24 weeks with a threatened preterm labor or short cervix. And the choice of progesterone and the administration methods all remains purely individualized. And a fixed cutoff of 25 millimeter of cervical length loses its clinical significance over the gestational age, because from 24 to 34 weeks, the cervical length as the gestational age advances. So a fixed cutoff for the whole length of period will again give a bias. And in the exclusion criteria, they have included only the history of conization. previous cervical procedures such as father hills or any other procedures were not included in exclusion criteria. So the
Jivita,
conclusion,
1 minute.
Ma'am?
Previous slide.
ma'am,
Previous slide. Yeah, limitation. This is the limitation you have taken from the article, or you have written on your own?
from the article, ma'am.
Yes. So see, the second point, authors cannot determine what influenced the attending obstetric decision to initiate progesterone treatment, and the choice of progesterone administration remains individual. They have told like that. But if you see in the methodology, they have clearly written that same brand of progesterone was given. The name is
Yes, ma'am.
only one brand.
something.
Only one brand they have included, ma'am. It is the
Utrogestrone 200 mg.
utrogestan.
Yes, utrogestrone they have given. But in methodology, they have properly written, but here in limitations, so these two are going against each other, isn't it? Okay.
Yes, ma'am.
Mm. Next.
Initiating that treatment is purely obstetrician's decision. Yeah, the choice of progesterone is the same, ma'am.
But in the article, in the study, they have recruited patients, all those who were given in their institute were given utrogestrone. And then they have, in methodology, they have also written clearly that everything was comparable. The dosage was also comparable in both the groups. If in certain group, people have received more number of vaginal progesterone, such were excluded. So in methodology, they have written something, and limitations, they are writing something else, isn't it?
Yeah, yeah. And one more
Yes,
thing that regarding the choice of like which patient to give the progesterone, those patients in the progesterone group more are having the high risk factor. Maybe they are little biased towards using those who are having like preterm labor, history of preterm labor, it is more in the study group. Similarly, the short service is also more in the study group. So maybe, yeah, so they are more.
Yes, ma'am. Their exclusion criteria is very strict. They have actually excluded all those with high risk factors.
Yeah.
It looks like they can only low risk. But when we see at the results, again, high risks are
High
appearing
risk,
more.
yes. They have given the progesterone treatment mostly to the high risk group. Because,
Yes.
and another thing, they have not excluded this primi, they have only written nulligravida, but whether how many primies or how many multis, again, it will change the cervical length also, it will change. Compared both primi and nulligravida and the multigravida differently, maybe it would have been a better like option.
Yes.
Yeah. Next, Jivita.
Yes, ma'am. So final conclusion based on this study is the progesterone treatment when administered between 24 to 34 weeks of pregnancy is effective and safe in preventing the preterm birth in women with a short cervix or an episode of preterm labor. And routine cervical length screening done after 24 weeks of gestation will help us pick up patients with the short cervix so that they would benefit from benefited from giving a vaginal progesterone therapy.
And another thing I want to tell here, like initially they mentioned those patients in the selection criteria having threatened labor preterm and also having short cervix. But we will see that concert chart, whatever they have put there, they have mentioned 154, I think they have excluded, they don't have any threatened preterm. Can you show that table? That flow chart. Before that flow chart, total number of sample size and this one. This one. See here they have written no threatened labor is around 154. But when they are included in the study, there they have mentioned those patients are having threatened because otherwise we don't do a like a transvaginal scan to see the cervical length unless the patient is high risk or presented with something after 24 weeks. That means all their patients who has come with the threatened preterm and they have taken those patients for the cervical length. But here then how it come no threatened labor in 154 patients? That part I also did not understand.
Yes, ma'am.
Yeah, this is one. Yeah. And one more thing, at least they are supposed to mention regarding the definition, how to diagnose the threatened preterm. That criteria should have been mentioned in the methodology.
Yes, ma'am. No criteria has been given to analyze the threatened labor, ma'am.
And which type of the study will be best to like study it some intervention or the treatment.
Ma'am?
Suppose this topic I would have given to you, what type of study you would have chosen?
Alternate study design, ma'am is asking.
Instead of retrospective cohort study, you're asking, ma'am.
Yes,
Yes.
yes. This is not the ideal
Case control study or prospective study will be more
Prospective,
beneficial, ma'am.
mostly it is a randomized control trial whenever you are like seeing the effective of any intervention or a treatment. Okay, so in that case, that would have been a much better to like in future, suppose you want to see the efficacy, then you should do a RCT to know what is the exact efficacy of this medication over the particular disease. Okay.
Yes, ma'am.
Yes.
Dr. Nivedita, anything else you want to tell?
So first of all, very good presentation. I have a few
Thank you.
comments to make, and while making my comments, I'll be asking some questions also, Jivita. So whenever
Okay,
we
ma'am.
start any journal club presentation, we should talk something about the journal also. So it's a very good prestigious journal, International Journal of Gynae Ops. It is a FIGO Society, okay, journal. Like for our
Oh.
Foxy, what is our journal? Foxy Society journal is JOGI, Journal of Obstetrics Gynecology
Yes.
of India. So this is our
Yes.
FIGO specific journal and its impact factor. So you have to talk something about that journal also. Okay, so 4.4, it's recent in 2023. So it's a very good journal. And this study has found place in such a journal, even being retrospective cohort. So there must be some strengths. And the strength of this study is the statistical part of it.
Yes, yes. That I wanted to
ma'am.
say. The statistical analysis is very important in this study.
Yes.
Yes, ma'am.
So yes. So whenever we present, no, you should not just stop with the conclusion what authors have told. You have to make your own critical analysis, critical evaluation of the journal. So it all starts with background. Okay, in the introduction, background about study title. What do you think, is the title appropriate? So whenever we form a title, it should be on PICO format, no? Population, intervention, control, and outcomes. So this title is very good. There is population, they have written more beyond 24 weeks of gestation. Intervention is progesterone, and outcome on preventing preterm birth. Okay, and it's a
Yes, ma'am.
retrospective cohort. There is a control also. So title is very good. However, they have not mentioned research question. You cannot do any study without any research. What they intend to do, what is the question? So that is not properly, or research question or hypothesis is not mentioned in the introduction. Because once we know question only, we can form the appropriate study design. Like telling now, RCT would have been a better appropriate design for this, so that we can do if good hypothesis is there, right?
Yes,
Then
ma'am.
even they should mention, will it change clinical practice? Will this study change? What do you think? Will you change your practice after reading this journal article? I will not change. Beyond
Yes.
24 low risk, I will not give until somebody does an RCT with good sample size and shows me significant outcomes. I will not. This does not generate level 1 evidence, generates only a weak evidence, isn't it? It's a retrospective cohort.
Yes, ma'am.
Yes, introduction is not well written. Purpose also, the objective of the study, why they want to do, just like that nobody has done after 24 weeks, so I will do. So some objective, why, that also is not mentioned in the study. Fine. Then again,
Yes, ma'am.
methodology, study design, we have discussed that it's okay to do, because but other alternative better would have been an RCT. Yes. And there are
Yes,
many
ma'am.
biases. They have mentioned that many biases are based on the obstetrician's preference and selection. Okay, because already drug has been given in one group and no group, and they're going back and retrospectively studying them. So obviously, multiple biases are there. Population bias. Okay.
Yes.
Now, what about study population? You think this is the population in which this study is done appropriate?
For a 7-year period, the number of
Yes. No, not that
is less.
population number. It's all high risk. This is a tertiary center. No? So everybody,
Yes,
all
ma'am.
the patients in tertiary center are high risk. But
Yes,
they
ma'am.
have, so can you, yes, they have excluded all high risk people and selected only low risk. But if you see this flow chart, again, no threatened preterm labor, 150, is lots of diversity in what they have told and what this flow chart
Being
suggests.
done. Yes,
This
ma'am.
cannot be generalized to low risk study. Like if you want to do this in a PHC and all those kind of settings, this study cannot be done. And what about sample size? We had a previous very good lecture. Is the sample size adequate? They have taken 121 and 363. So since it's retrospective cohort study, it is
Yes, ma'am.
okay whatever sample size in that particular period of time. So that need not be questioned, though they have not mentioned how the sample size calculation formula was used. Okay, but it's a time-based study, so fine. No, the strength of the study is statistical analysis. First of all, they used multivariate analysis to look at the risk predictors of spontaneous preterm labor, then Kaplan-Meier survival analysis, that induction diagnosis delivery interval,
Diagnosis delivery interval, yes, ma'am.
at which period of gestation preterm birth happens in drug group and no drug group. So that is a very good statistical tool, Kaplan-Meier survival. And Cox proportional hazard model is to look for complication, okay, associated in treatment and no treatment group. So even with treatment, preterm, whether preterm birth has happened, NICU admission has happened, okay. So those things they have applied, and they have shown that in treatment group, this NICU admission is lesser and spontaneous preterm birth less than 37 weeks is also lesser. So these are the strength of this article, okay.
Yes,
and very all statistical tests they have very appropriately used. Now coming to the results also tables they have clearly presented. Okay, we are able to understand once we look at the table, because it's a simple retrospective cohort study, we are able to easily understand from the table. Okay,
Yes,
now coming to the final discussion. So discussion they have written quite enormously. Your slides, of course, in presentation you cannot include so much, so you have put only 2 slides on discussion. But if you see, they have written a very good discussion. Okay, discussion means actually comparing your study with other
studies.
Pregnant trial, okay, that you could have brought. What is pregnant trial?
Pregnant trial was administration of vaginal progesterone before 24 weeks of pregnancy.
Yes,
to...
so with progesterone, the results are consistent, and this study results are also consistent with pregnant trial. So that we have to test. So we should always compare your article with other previously done trials. Okay.
Okay, ma'am.
And strength and limitations also well written, well taken. And
limitations, like just limitations, they have written very nicely. So whatever limitation they have written very nicely. They have make it understood what are the limitations of the study.
Yes, ma'am. Yeah. Yes, ma'am. And finally, conclusion. Can you show me your conclusion slide? The conclusion should always be, yes, short conclusion. No, I mean, reading your conclusion, we should be able to make out what has been done in the study, so that they have properly supported with data. The findings of current study suggest that progesterone treatment between 24 and 34 weeks of pregnancy is effective and safe in preventing. Okay, so that data also, I think it's there in the article, and you have not mentioned how much effective it is. Effective and safe, but how much? So they should always, with the numerical data, they should conclude. Okay, we cannot write it is better or it is not efficacious. And comments on additional questions for future research. This also they have concluded, but this study is not enough. This calls for a good randomized trial with good sample size. So their discussion is really very well written. Statistics analysis of this article is the heart of the study, and that's why it is found in FIGO journal. Okay, FIGO Society journal, International Journal of Gynecology. So this is one of the best journals in obstetrics and gynecology. Our best journal is BJOG, Green Journal, AJOG, 7 Impact Factor, and then this one. So it's very good. It is a very good article which we have selected, very relevant. And even I got to learn so much from this article. So I really thank the organizers and moderator and the presenter. Thank you so much.
Thank you, Nivedita. Even I also, when I thought the journal, I was just searching the journal. Then I saw the topic. I thought it is a retrospective, that course study, why they have taken in a such a. Then once I read the this particular statistics part and other things, so it was then I thought, okay, maybe that is why they have decided to take this article for publication.
Multiple retrospective cohort study only forms basis of future RCTs. So this is the beginning. Maybe Nivedita will be able to do an RCT on this topic. Yes.
There is a question in the chat box, like by Dr. Sahnaz. She has asked, like, explain the role of cervical circlage also in preterm birth after 24 weeks.
See, in preterm birth after 24 weeks, usually we give only the emergency circlage. That can be given up to 28 weeks. So either it is a prophylactic circlage, which you called as a history indicated, or it is ultrasound indicated circlage. That is not given after 24 weeks. After 24 weeks, the circulation is given. That is only the emergency circulation.
Emergency circulation.
When like you see the membrane is bulging or the cervix is dilated, where you put circulation you put. So that is basically after 24 weeks means it is basically the emergency circulation. Usually prophylactically what you put, like any history of previous either 2-3 abortions or 3 preterm labor history indicated, you put around 12 to 14 weeks. Like after you rule out the like any congenital anomaly after the NT scan. And if it is like a patient is having or 1 or 2 any preterm delivery or a mid trimester abortion with ultrasound evidence of any short cervix, that when you do the anomaly scan around 18 to 22 weeks, during that time, so you are like during the NT scan, that time you can put which is a ultrasound indicated circulation. After 24 weeks, basically it is only the emergency circulation. Whoever comes with a short cervix with membrane bulging, there you can put.
One more thing I want to add in this study, since retrospective ethical concern is not there, but see, after 24 weeks, they excluded all the high risk, even people who were on progesterone for
Yes.
some history indicated, or those who are on surplus, they have excluded. So after 24 weeks, why would anybody do cervical length and administer? So this thing is difficult to understand.
No, I think why they have taken that initially those, I think after 24 weeks who has come with a threatened preterm only, because otherwise we don't do a cervical length measurement after 24 weeks without any risk factor. Routinely we don't do. Maybe they have mentioned that patients who have come with a threatened preterm, those patients they have done the cervical length. It can though sometimes they have mentioned it is a low risk, but low risk, why would you do a cervical length measurement without anything after 24 weeks? Usually you do the prediction means before 24 weeks in the mid trimester, you do the cervical length when you're doing anomaly scan and all that time, and anybody having a short cervix with history, you give any form of progesterone or a circulation, whatever it is indicated. Even if you see the yeah, you can ask.
No, ma'am, you continue.
No, in NICE guideline, even like if the patient is having a short cervical length in a like around 20 week scan, mid trimester scan, and she's having one history of either one preterm or a mid trimester abortion, there you have the two choice. Either you can give a cervical circulation or you can give a vaginal progesterone up to 34 weeks. That guideline is there. If it is an incidental finding of short cervix with a history of preterm labor or a like mid trimester abortion, but only incidental finding of short cervix, usually no treatment is given as per the recommendation without any risk factor.
Yes.
Yeah.
How do you manage preterm labor in your setting, Jivita?
Ma'am?
Preterm labor?
After 24 weeks, ma'am, or?
Preterm labor. Obviously, it will be after 24 weeks. Yeah. So how you manage?
We'll just we'll do a scan, ma'am, initially.
Yes.
Just to associate if there is any shortened cervix, we'll see for it. And also we look for the source of infection, any unitract infection is there or any profuse vaginal discharges are there which can be treated, which is causing the preterm labor. And we'll start them on antibiotic if any suspicious infection is there.
Anything important?
And, we administer antenatal corticosteroids, ma'am.
Yeah.
And to arrest
sorry, ma'am?
To arrest the contractions.
What do you do?
No, ma'am. In case after 24 weeks, the chances of with our NICU setting, the babies, even if they deliver, the chances of saving the baby is more. So
no, madam is asking. No, madam is asking when you are giving a steroid, you are giving for lung maturity. No, you do.
Yeah, for the baby
your baby for the baby immediately. It is
for the.
So what do you do during that time when you are giving the steroid?
Tocolytics till the time to prolong the ma'am.
Which tocolytics you prefer?
Nifedipine we are giving, ma'am.
Okay.
How long you give nifedipine?
For 48 hours till the cover of that steroids, ma'am.
So there is no role of any tocolytic therapy, man, like continuing beyond that. Only tocolytis is given only for the coverage of the steroid coverage during that time.
Yes.
And what about neuroprotective Maxil, magnesium sulfate neuroprotective?
Magnesium sulfate we give up to 31 weeks, ma'am.
32.
4 grams IV we give, ma'am, till 31 weeks, ma'am.
4 gram IV, 1 gram? for our IV infusion, no?
After that.
Yes, ma'am. Followed by.
Okay, so that is up to 32 weeks. It is not only 31, up to 32 weeks you need the neuroprotection.
Okay, ma'am.
We are routinely doing that. Nice to interact with you, Jivita and ma'am, Sunita ma'am.
Thank you, ma'am.
Thank you, Nivedita. Because I was so much associated with Pondicherry for 11 years I have spent there. So, Sir, Rani Madam, Lata Madam, so many, all Dilip, everybody, all faculties I know. So that's when I saw your name, then I was thinking, I think she has joined new. So you told you have joined 2018. I left Mahatma Gandhi in 2017.
But I know you for a long time. When I was UG now, from that time only, we used to attend there.
Okay. Yeah, thank you, Dr. Nikita. Your presentation was very nice. Last time also I attended your presentation because as a obstetrician, we do this, particularly the statistics part and this designing of the studies, it is very difficult to understand unless you do it routinely and regularly, or you teach your students. So it is not the students, we are also learning a lot from your presentation. Thank you so much.
Yes.
Thank you, ma'am. Glad to hear that. Happy to help.
Yeah.
Okay.
So thank you, ma'am, for being a good captain, and Nivedita ma'am for becoming a very good umpire. So the match is over. Jivita has been a very good player. So I hope she will continue being a good player. And as Nivedita ma'am told, she's going to do a RCT next. So, and Nikita ma'am will help in studying the the study, whether any biases and confounding factors are there. She is there always for us. So, okay, thank you all. Now over to Dr. Priya ma'am. I think it's time for vote of thanks. Priya ma'am.
Yeah, sorry. So, thank you. That was such a wonderful discussion, madam. You went through each and every step of the journal, including whether they have discussed the discussion properly, conclusion properly. It was, such a pleasure to hear from both of you. So, the actual journal club where you went every step, including the table and a lot of tips for the postgraduates. So it was a wonderful discussion. And Dr. Nikita, thank you for your lovely speech. We have been hearing modules from her. I think the postgraduate will get benefited with all these things. So we even have a recording. So people who have missed, we would like to share the video. There is also a YouTube live. So you can go through these. You can just tell your friends who can go through that. So it will be useful for them. So thank you, Dr. Nivedita madam, and thank you, Dr. Sunita madam, for accepting that. It has been a pleasure having you both here. And thank you, Maitri. You did a excellent job for us for throughout the program for the Master of Ceremony. And thank you, Gundavi madam. You stayed till the last. And all our delegates who attended today, thank you, and thank you everybody on behalf of OGSSI for your extended support. Thank you.
And thank you, Shield.
Thank you,
Shield also.
And thank you, Shield and Chitrakala and Sahitya. Yes, sorry. They have been are always
part and parcel.
As well as madam. Even when the last minute when we fail and we go and ask them, please get a link. The next day, next minute they don't hesitate to give us a link, and they have been very supportive. Even when we have technical glitches, they say you pass on the slide, we'll share it for you. So it has been it always goes smoothly because of Shield. So thank you.
Yeah.
Thank you, ma'am.
Actually, I would like to thank Jairani madam, Kundavi madam, and Priya, all three, because you have made this one research committee, OGSSI, different committee. Yeah, it's good actually, because we never used to discuss this thing. So every month we can have a discussion and everybody will get benefited, particularly the students, even faculties. It is not only faculties knows everything. So we also learned a lot from these presentations and all. And because of presentation, we are going through the study, we are also trying to find it out, how to analyze, critically analyze any journal article. Yeah, thank you everyone. Thank you so much.
Thank
you for giving me the opportunity also. Thank you.